hallucinations, which is when a number of different voices are talking about the patient. And the last primary symptom, which is a hallucination, is that of a voice coming from another part of their body. For instance, their little toe is speaking to them.
Are there any other primary symptoms, or have we covered them all?
The last one is a persistent delusion, which is culturally inappropriate or impossible, and classically has a bizarre nature to it.
You say classically it has a bizarre content, but I suppose, of course, it might be a fairly ordinary content, and that might make it quite difficult to detect.
Yes. For instance, the fact that I might be going out with the Queen is theoretically possible, and therefore not a primary symptom. The fact that I might be the Queen is impossible, and therefore is a primary symptom if it is persistent and culturally inappropriate.
Thanks. What about the secondary symptoms? Can you tell me what those are?
Yes. Secondary symptoms start with persistent hallucinations of any modality within any sense. For instance, an olfactory or smell or visual hallucination, for instance, which is accompanied by a fleeting or half-formed delusion. Thought disorder, which is, presents as incoherent or irrelevant speech, but can often be experienced as confusion by the patient. Catatonic behaviour, which is a disturbance of psychomotor function, actually can be observed in a variety of disorders. And negative symptoms, including apathy, blunting of emotions, and social withdrawal.
Can you say a little bit about the prognosis of schizophrenia?
Yes, schizophrenia is a major cause of disability, and although most people with schizophrenia live independently, they do often require some degree of ongoing management from mental health services and community support services. People having a first episode of psychosis roughly have a 1 in 3 chance of a good long-term outcome with no further episodes. Another third tend to have a relapsing remitting course, and roughly the last third tend to have more of a poor outcome with some ongoing residual symptoms. Other factors that affect prognosis include response to antipsychotic medication, ongoing drug use or life stresses, and frequent exposure to situations with a high expressed emotional content.
Can you say what you mean by that?
Yes, it's really important to have a low stimulus environment. It's important that patients who have schizophrenia aren't exposed to, for instance, difficult arguments or fights or situations with a high emotional content. Does that make sense?
Yeah, I think that does, yes. Does schizophrenia affect life expectancy?
Yes, schizophrenia does result in a decreased life expectancy of between 12 and 15 years. Although this is primarily because of its association with obesity and sedentary lifestyles and smoking. Suicide also plays a role in increasing the risk, although not as much as with bipolar disorder. People with schizophrenia have an increased risk of cardiovascular disease, and that's why promoting good physical health is really important, and being aware of the risks associated with some of the long-term antipsychotic medication we give patients. And because of these factors, it's really important that metabolic monitoring, such as fasting lipids, glucose, amongst other blood tests, should be performed every 3 to 6 months.
Can you actually cure schizophrenia?
Well, no, you can't. But there are effective treatments that can significantly improve symptoms. The most suitable paradigm potentially for thinking about the management of schizophrenia is that of chronic disease management. It's a bit like managing diabetes in a way. You can't cure diabetes, but you can manage it very effectively. It's an ongoing condition, schizophrenia, that requires long-term medication and lifestyle modification. But with the correct package, the person can do very well.
it's good to have an encouraging message, because I think it is a condition which can be very difficult, can be very disabling. So it's good to know that with the right supports, people can live well. Could you say a little bit more about the management, and first tell me a bit about the pharmacological management?
The mainstay of treatment pharmacologically is antipsychotic medication. There is interestingly little evidence for any difference in the efficacy and effectiveness of the different antipsychotics. We talk about first generation and second generation antipsychotics a lot, and actually the main way that they differ is not necessarily in their efficacy, but more in the different side effects that they give. So NICE guidance actually suggests that you should discuss with the patient what medication would most suit them by reviewing each medication's side effect profile.
Can you say what the side effects are with each of those groups of drugs?
Yes, most antipsychotics do give you some level of sedation, but the two main groups of antipsychotics each have their own characteristic side effect profile. First generation antipsychotics such as haloperidol have movement side effects. We call these extrapyramidal side effects. They're called extrapyramidal side effects because they affect the pathways in the brain and the spine to do with movement that are not the pyramidal tracts, hence extrapyramidal. And the second generation antipsychotics, such as olanzapine or quetiapine, tend to cause more weight gain and tend to be more sedative again, over and above the first generation antipsychotics.
What would happen if antipsychotic medication isn't effective?
If a patient has been trialled on 2 antipsychotics at a reasonable dose for at least 8 weeks and remains experiencing significant symptoms, then we would look to thinking about the medication called clozapine, which has been proven to be effective in treatment-resistant schizophrenia. Clozapine's use is restricted because it has a serious side effect of causing agranulocytosis. So we use clozapine, and it is actually a very good medication, but we need to do several types of monitoring before they start clozapine, and then we'd need to monitor their full blood count every week for 6 months, and then every other week for the year, and then monthly thereafter. After we've tried clozapine, we would move towards different combination of antipsychotics, but this really is best avoided if possible, given the risks associated with combinations of antipsychotic medications. And in this case, if we do use polypharmacy, then extra physical monitoring of the patient is required.
Given some of the side effects associated with antipsychotics, would psychological therapies be appropriate for schizophrenia?
Yes, psychological treatments would be appropriate, but I think it's important to realise that patients do need to have pharmacological therapy as their mainstay of treatment. Psychological treatment would be seen as additional to the pharmacological intervention. And CBT can be used in schizophrenia and has been seen to help reduce anxiety and paranoia associated with chronic psychotic symptoms.
So CBT is targeting the psychotic symptoms particularly, and how patients experience those as a way of reducing the distress caused by them.
That's right. CBT doesn't challenge the delusions necessarily or the experience of hallucinations. It rolls with the experiences the patient has and says, okay, well, if you do feel followed all the time, how can we help you with that belief? Another psychological treatment is family therapy, which, as I mentioned earlier about high expressed emotions, family therapy is a specific intervention to try and reduce that. If high expressed emotions are present in a patient's family, it can seriously affect their prognosis.
How about social interventions? Can they be helpful for schizophrenia?
Well, yes, social management should always be a fundamental part of a patient's care package. Schizophrenia can be socially isolating and can lead to difficulties in maintaining independence. And for that reason, a social worker can help sorting out their benefits and their housing, An occupational therapist can help structure day activities and monitor safety in the home environment. And a support group can help with the patient's recovery, as can ensuring that the patient has adequate employment support and advice.
Is there anything else that we should think about in terms of management?
Well, the fact that the experience of being psychotic can be so very alarming and distressing, that can lead to the patient posing a significant risk both to themselves and others. And this, alongside the frequent lack of insight that is associated with schizophrenia, can mean that admission to hospital is required. It may also be that the mental health act is needed to admit the patient against their will for assessment and treatment. But admission is usually reserved for those cases where community management has failed, or where the patient poses significant risks to themselves or others.
Before we finish, are there any final points that you'd like to make?
Well, I think what mustn't be forgotten is that if the patient has a carer, then reviewing the carer's needs is important as well, as a psychotic illness can have a big impact on those closest to the patients. So in this case, a carer's assessment and referral to a carer support group can be very helpful.
Thank you very much. That was a good overview, I think, of the causes of schizophrenia and also the approaches to treatment and management. I hope that's been useful for our listeners. Thank you very much.